At the end, we will learn about causes, clinical features, investigations and management of primary hyperaldosteronism. And one important thing to know is, if in hypertensive patients there are indications like hypokalemia, there is poor control of blood pressure, that is, patient is taking more than 3 drugs for controlling blood pressure but is not being controlled, that is, it is drug resistant. If there is family history of early onset hypertension, if hypertension is present at young age, and if there is adrenal mass, then in such indications, such cases, along with the hypertension, mineralocorticoid excess should be suspected and screening should be done for knowing whether there is mineralocorticoid excess or hyperaldosteronism. There are 3 important causes of primary hyperaldosteronism. The most common cause, accounting for 60% of the cases, is idiopathic bilateral adrenal hyperplasia. In this disease, there is hyperplasia of the zona glomerulosa cells of the adrenal gland that produce aldosterone. The second most common cause is aldosterone producing adrenal adenoma. When we compare the patients of idiopathic bilateral adrenal hyperplasia and adrenal adenoma, then these patients, they tend to be slightly older and present with less severe hypertension than adrenal adenoma. Next is glucocorticoid suppressible hyperaldosteronism. It is rare cause. Actually, aldosterone synthase is not under the control of ACTH, and zona fasciculata and reticularis, in normal adults, they do not produce aldosterone. But in this disease, there is a rearrangement in the chromosome 8, such that now aldosterone synthase comes under the control of ACTH, due to which zona fasciculata and reticularis, they start producing aldosterone. So why it is called glucocorticoid suppressible hyperaldosteronism is when exogenous glucocorticoid, that is dexamethasone, is given, it suppresses ACTH. When ACTH is less, then these zona fasciculata and reticularis, they cannot produce aldosterone. So excess primary hyperaldosteronism here means there is intrinsic abnormality in the adrenal gland. So these all 3 causes, they are the intrinsic abnormalities of the adrenal gland. So when excess aldosterone is produced, then this aldosterone acts on the renal epithelial cells, that is principal cells of the kidney, and causes reabsorption of sodium from the renal tubule to the blood vessel, and excretion or secretion of potassium from blood vessel to the renal tubule, and potassium will be lost into the urine from renal tubule. So it will cause hypertension because of reabsorption of sodium along with the water, and it will cause hypokalemia because of excretion of potassium ions. Before knowing the clinical features of primary hyperaldosteronism, let's first recall the functions of aldosterone. Aldosterone, it acts on the principal cells to increase the synthesis of proteins like sodium potassium ATPase on the basolateral membrane, epithelial sodium channel protein on the luminal membrane, renal outer medullary potassium channels on the luminal membrane. From this we can understand that aldosterone, by acting on the principal cells, is causing reabsorption of sodium and excretion of potassium, that is causing sodium retention and potassium wasting. Aldosterone, it also acts on the type A intercalated cells to activate the hydrogen ATPase present on the luminal membrane to increase the hydrogen ion excretion. So it will cause metabolic alkalosis. Usually the patients of primary hyperaldosteronism, they are asymptomatic, do not show any symptoms, but they may show the features of sodium retention. Because of sodium reabsorption, there is also reabsorption of water. It will expand the extracellular fluid volume and plasma volume to cause edema. There is potassium loss, that is hypokalemia. Hypokalemia, it causes muscle weakness and sometimes paralysis. Hypokalemia, it damages the renal tubules, which causes nephrogenic diabetes insipidus, and there is polyuria. So symptoms like nocturia, increased urinary frequency, and enuresis can be seen. Potassium loss along with the metabolic alkalosis and low ionized calcium ions causes tetany. So since there is increased plasma volume, there will be increased blood pressure, that is hypertension. And if this hypertension is treatment resistant, that is drug resistant, then the likelihood of primary hyperaldosteronism being the cause will be high. Investigations for primary hyperaldosteronism can be classified as biochemical investigations and imaging and localization. In biochemical investigations, screening and confirmation of diagnosis is done, and by imaging, the cause for primary hyperaldosteronism is found out. If there is primary hyperaldosteronism, in the routine blood test there will be hypokalemia, there will be metabolic alkalosis, and there will be slight increase in the sodium ion, but there will not be hypernatremia. It is because along with the sodium reabsorption, water will also follow it. Screening is done by detecting the aldosterone by renin ratio. In primary hyperaldosteronism, there is excess production of aldosterone from the adrenal gland. This excess aldosterone will try to inhibit the renin production by negative feedback. So this ratio will be high. So if aldosterone by renin ratio is greater than 750 picomole per liter, then screening is said to be positive. So if the patient is taking antihypertensive drugs, then these drugs may interfere this ratio and will show false positive or false negative result. That's why we should avoid these antihypertensive drugs for at least 4 weeks, and then screening is done. If again screening is positive, then it is positive. So how antihypertensive drugs they alter this ratio? Let's see. Beta blockers, it inhibits renin, so the ratio will be falsely high. Diuretics, they stimulate the renin production, so ratio will be falsely low. Angiotensin converting enzyme inhibitors or angiotensin receptor blockers will inhibit aldosterone, so ratio will be falsely low. And if there is severe hypertension, then avoiding the antihypertensive drugs for 4 weeks will result in hypertensive crisis. That's why other antihypertensive drugs that have low effect on the renin, angiotensin, aldosterone axis should be given, like calcium channel blockers and alpha blockers. Now if screening is positive, then confirmatory test is done. Confirmatory tests, they can be done only by endocrinologist. The tests that are used are saline infusion test, oral sodium loading. They are different tests, and most common test done is saline infusion test. In this test, 2 liters of saline is given over 4-hour period. So when sodium level will be increased in the blood, then it will try to suppress aldosterone. But in primary hyperaldosteronism, there is autonomous secretion of aldosterone from the adrenal gland, so aldosterone will not be suppressed. And even after giving this saline, if aldosterone is measured to be greater than 140 picomole per liter, then confirmation of diagnosis is done. Now let's know the cause of hyperaldosteronism by imaging. In CT or MRI is important investigation, but it may show false positive result and false negative. False positive if there is non-functioning adrenal adenoma, and false negative if the adrenal mass is less than 0.5 centimeter. Then CT or MRI may not have resolution to detect these lesions. Adrenal vein sampling is indicated in if CT or MRI shows unilateral adrenal mass and if the patient is greater than 40 years. Because in this group of patients that is greater than 40 years, if CT or MRI shows unilateral mass, then it is usually inactive or non-functioning adenoma. So this should not be removed by surgery. For example, in the right adrenal gland, CT or MRI shows adrenal mass. Patient is greater than 40 years, so this mass may be non-functioning. But there may be radiologically inapparent small lesion less than 0.5 centimeter in the other contralateral adrenal gland. So if the surgery is done only after CT or MRI, then this gland will be removed. But hyperaldosteronism will not be relieved because there is radiologically inapparent lesion on the contralateral adrenal gland. So in such condition, adrenal vein sampling is indicated. management of primary hyperaldosteronism, it depends on the cause. So according to the cause that is causing, and the treatment will differ. Let's start from the most common cause, idiopathic bilateral adrenal hyperplasia. In this disease, surgery is not indicated. Medical therapy is given, either spironolactone or amiloride. If spironolactone is given, it is started from 12.5 to 50 mg 2 times a day, and it can be given up to 400 mg per day. Alternative to spironolactone is amiloride. It is started from 25 mg 2 times a day and can be given up to 200 mg per day, just half of spironolactone. The side effects of spironolactone are menstrual irregularities, decreased libido, and gynecomastia. If the cause is aldosterone producing adenoma, it is also known as Cone syndrome. It is unilateral and solitary. Then surgery is done, that is unilateral adrenalectomy. But before going for surgery, medical therapy is given, that is spironolactone or amiloride is given to correct the hypokalemia, to correct blood pressure. And if the cause is glucocorticoid suppressible hyperaldosteronism, then there is no use of giving spironolactone or amiloride because pathogenesis is quite different. So in this disease, dexamethasone, that is exogenous glucocorticoid, should be given in the dose 0.125 to 0.5 mg per day.